Good morning and welcome to Sharon Solutions for Home Health Care Agencies. Today we're going to be discussing best clinical practices related to the patient-driven grouping model. But before we get started, I wanted to talk briefly about the rationale of why CMS is changing the payment system. So number one goal for CMS is better health care across the community, especially between post-acute facilities, effective care coordination, and case management of those patient services. Number two is better patient care. And of course, who wouldn't want better patient care? We want to see our patients improve at the end of our encounter. But best patient care is provided through evidence-based practice. So we're no longer silos doing our own thing out here. We have to take hold of evidence-based practice and make sure that our treatment and our services include best practices. Number three is lowering the cost. Of course, CMS wants to ensure that they're paying us appropriately for the services that we're providing. And they're watching every dollar and squeezing out of us every penny for sure. But on our end of things, we also need to ensure cost effectiveness, and we need to be good stewards with the money that CMS is giving to our agencies so we can provide services to our patients. So better health care overall, better patient care, and lower cost. That's the reason in a nutshell. So let's get started. So what can I do as a clinician through best practices? Number one is OASIS competency and expertise. It is crucial that you as a field clinician understand the intent of each OASIS item, especially those functional items. And the reason being is that the new payment structure includes a level of functional impairment. And that functional impairment is going to affect our reimbursement potential. So the items that you especially need to hone in on today are those M1800 items: grooming, upper and lower body dressing, bathing, transferring, and ambulation. Interesting enough, it doesn't include the GG items because those GG items by President Obama's Impact Act of 2014 have to do with providing effective care coordination between those post-acute facilities. But the M items, those M1800 items, are imperative that we understand that we are assessing the patient's safe ability versus actual performance. So that has not changed. If the patient's at risk for falls, we need to assess that or add that into our assessment and our responses to our OASIS. So that is huge, and we need therapy evaluations and occupational therapy evaluations to happen within that 5-day window that CMS has granted to us. So please ensure that you have good care coordination between disciplines, and ensure also that you know the intent of the items that are going to affect reimbursement. One of the other items, interesting enough, is the M1033 item, hospitalization risk. It is an item that is mark all that apply, and so we have to ensure that we are marking all those responses that apply. There's a fall response. There are various other responses, but the one I want you to think about today is other. It's number 9. And other opens the gate wide open for us. Does the patient live alone? Do they have an elderly caregiver? Do they have comorbidities that affect rehab potential? Or I first lost my train of thought. But anyhow, you get the picture. We want to ensure that number 9 is marked regardless. All of our patients have those other conditions that affect their rehab potential or the outcomes to this home care encounter. So OASIS competency is huge. So we want to champion someone or a group of someones who are certified in OASIS. And that certification can be obtained through special training and then is kept updated on a yearly basis. So that's big. We want to champion those type of people that love OASIS. So that may or may not be you. So number 2, after our OASIS competency and expertise, is our coding expertise and competency. And that is also big in the patient-driven grouping model. And the reason it is most likely is that it affects reimbursement in a huge way. So our primary diagnosis is important, as well as 24 other spots for reimbursement potential, and that's called case mix adjustment. And so it's very important that we get all of those diagnoses assigned that affect this plan of care and rehab potential. In fact, the condition of participation now says diagnosis, and then in parentheses it says all known diagnosis on the condition of participation. So you're going to be seeing that assignment of diagnosis list grow rather long, and that is the reason why. But what I want you really to know about diagnosis is that there's a group of diagnosis that the CMS will no longer allow, and that those diagnoses are things such as osteoarthritis not otherwise specified, rheumatoid arthritis not otherwise specified, pain to a specific joint, low back pain in general, debility, muscle weakness, generalized weakness, abnormality of gait, repeated falls, all of those codes that we see on a regular basis, right? And so we're going to have to get tough with our physicians who are giving us orders for home health care, and hopefully your intake department is going to be doing that as well as your marketers, because this is going to be a very painful transition for a lot of agencies who are accepting referrals with these types of diagnoses. So by the time it comes to a company like mine and to our clinicians that are certified in ICD-10 coding, we're sending it back to the QA nurses or to the agency and saying, we can no longer accept these type of diagnoses as primary diagnosis. Now, we may be able to accept them in the case mix comorbidity section. However, it will serve no purpose to put those diagnoses on the claim, and the reason being is that they will provide no reimbursement potential whatsoever. So be aware of that. We may just have to tell our physicians what we want, and that's not difficult to do. It is also a best practice to tell our physicians what we want with that S-bar technique. I'm sure you guys have heard of that before. But for instance, I had a patient who was waiting a hip replacement, and the diagnosis on the order said pain to the right hip. So the pre-evaluation for surgery said that they had degenerative changes to the right hip. However, they never once said that it was osteoarthritis to the right hip. And so I sent it back to the QA nurses and I said, hey, we need a diagnosis, a specific diagnosis. And they reached out to the doctor and they said, you've got all that you need. It's like, no, I don't have all that I need. And so I sent it back to the QA nurses again. And I said, okay, write the order for OA to the right hip and send it to the physician for a signature. Okay, wise as serpents, harmless as doves. We have to tell the physician what we want, and they expect us to. It's very difficult to be a physician who's signing orders for home health care because of all the government regulation, and this is just another one. And hopefully we're going to be proactive from this point forward before January 1st so we can get our physicians on board. So we have OASIS competency and expertise, coding competency and expertise. And I trust that you have certified clinicians who are providing your coding for you. And you certainly do with SMC Home Care Solutions, because all of our clinicians are certified and we are running weekly QA audits to ensure that we provide excellent service with and expertise with every patient assignment. Okay, so number 3 is care coordination, effectual care coordination and case management. And this is, we've talked somewhat about it, not only post-acutely between facilities, but amongst ourselves as clinicians. And so CMS has given us that 5-day window for the PT and OT evals to give their input, or the PT and OT therapist to give their input after their evaluation. So please take advantage of that free 5-day window gift that CMS has given us. They expect us to use it in gathering the data that is necessary to paint the entire picture. So talking about painting a good picture in home health care, we need to stay away from subjective data, subjective terminology that leads us nowhere, debility, taxing effort, superficial, skin tear, those kind of things. Just we need to describe and paint that picture using objective data so that everybody knows that we're talking about a partial thickness wound or a wound with eschar covering 50% of the wound bed. We need to be very specific and paint that picture. So documentation is huge, painting the big picture, letting go of subjective assessment data and terminology that is vague, and just care coordination between ourselves, not being a silo, working together as a team so that everybody achieves more, everybody knows more. So I think that's all I really wanted to say this morning. I want us to remember the big picture so we don't get totally frustrated and throw our hands up in the air and say, I hate home health care, because we don't. If you've been here any length of time, it's because you love home health care and you love what you're doing. So God bless you guys for everything that you're doing to ensure better health, better patient care, and lowering the cost. God bless and have a good day.